Let me welcome everybody to this pep talk. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, or email address in the chat box. Please include the names of the companion attending for complete attendance. Use the chat box to ask questions and make comments while the pep talk is on. There will be a group pictures at the start and end of the pep talk. Okay, so please show your face in the video during the group picture taking. As a reminder, please take the online OLETE evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. I have placed the link in the chat box, not yet, later on probably, but I have placed the link in the Facebook page and also in the Viber group. As a reminder also, getting 50 OLETE certificates will entitle a mentee to one voucher for a free telemedical consultation. So welcome again. Let's now have a group picture taking before we start the pep talk proper in 2 minutes. Please show your face now. Okay. One. Are you all ready? 1, 2. Okay. There's a pahabol. 1, 2. Let's wait for Jeanette. Okay. Okay. Let's have a group 1, 2, 3. Okay. Let me okay. Okay, let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. And I'm now starting to tackle the health disorder, and health issue courses. I'm starting with the health disorder courses. This may take about 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Cancer, which is part of the cancer course. This is actually part 2 already. Okay, so the empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of cancer. So some definition of terms in the title and the limitation of the coverage of my talk because I cannot cover everything. Fundamentals means simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Generalities means just general statements of information, not covering specifics and not too detailed. Medical management means diagnosis and treatment of breast cancer, This is, sorry for this, this is for next time, okay? Cancer by the physicians. So last week, we tackled this part 1, screening of cancer, symptoms that will lead to suspected presence of cancer, clinical diagnosis of cancer, and paraclinical diagnostic procedures for cancer. Today, we will be tackling part 2, treatment of cancer, surveillance, prognosis, and palliative and hospice care for cancer patients. So let's start with treatment for cancer. First thing to do before considering and comparing the options of treatment methods or modalities of treatment for cancer is to spell out the specific objective or goal of the treatment. It is whether the treatment goal will be curative or palliative. Curative goal means eradicating all known, all evident tumors or cancers entirely and toto, preventing the recurrence or spread of the primary cancer. So this is the definition of a curative goal, whereas palliative goal is just relieving the symptoms after all reasonable curative approaches have been exhausted. Okay, so it's not curative anymore. Okay. At the time of the treatment, the patient may present in a cancer stage in which the goal is at best palliative only, just relieving the symptoms. These are usually in the patients with advanced cancers. But for patients presenting with early stage cancers, the goal is usually curative, that is eradicating all the cancers and tumors entirely and preventing recurrence and spread of the cancer. Thus, the objective of treatment is primarily, okay, there are other factors that will have to be considered, but essentially it is dependent on the stage of the cancer at the time of the treatment. Staging and stage of the cancers just means describing the extent of a cancer present in a particular patient. There are so many ways of staging cancers. One such is, say, classify it into early stage or advanced stage. This is the simplest classification. The other one is localized, regional, distant. Regional means to the lymph nodes in the area. Okay. Localized, early localized advanced, late localized advanced, and metastasized. This is another method of staging the cancer. The most popular one is the in the medical world is the so-called TNM staging. So this describes specifically the size of the cancer. Okay, these are for TNM is actually for solid tumors because you cannot describe the size of the blood cancer. So it describes the size of the cancer and how far it has grown, whether it has spread to the lymph node or to distant organs. Okay. So TNM stands for T, the tumor, okay, N, nodes, M, metastasis. Okay. So stage 1, localized, usually just with T, small size, and then stage 4, those with distant metastasis. The moment you have distant spread to other organs, automatically it's stage 4. Okay. In between are stage 2 and 3. So stage 3 is more advanced than stage 2. There are a lot of cancer treatment being advocated. These are classified into mainstream ones and non-mainstream ones. Okay. So mainstream ones are those accepted by and being promoted by majority of physician cancer specialists. These are also called conventional or standard treatment. So these have well-documented evidences for effectiveness in various degrees. I mentioned in various degrees, it's not 100%. Okay. Non-mainstream ones are those outside, by the term itself, outside the mainstream ones. So it's the commonly used term is alternative medicine, an alternative to the mainstream ones. Okay. Usually, the health claims here are not or does not meet the evidence-based standards in the medical world. The mainstream modalities of treatment for cancer are currently the following. There could be more in the future. Okay. Surgery, number 1, surgery. Okay, this is essentially an operation. It involves cutting of body tissues and organs. Radiotherapy, involving the use of radiation. So essentially, it's burning the cancer. And then chemotherapy involves the use of drugs. So killing the cells, the cancer cells. Okay. Hormonal therapy, you manipulate the hormone milieu of the body. Immunotherapy, immune system manipulation. And then targeted therapy, usually gene manipulation. The Mainstream modalities of treatment can also be classified into two types, whether they are localized or systemic. Localized treatment means these are those that are directed to specific organs or limited areas of the body. Okay, so the treatment is being done on a limited area, such as the breast. You remove the breast, okay, you radiate the breast, or abnormal growth in other parts of the body like the skin. So examples of localized therapy are surgery and radiotherapy. Systemic therapies are those using drugs and other substances, chemicals that spread throughout the body to treat cancer cells wherever they may be. Okay, so they include chemotherapy, hormonal therapy, targeted drugs, and immunotherapy. So cancer treatment may be single or combined modalities depending on the track records of effectiveness. Okay. So you can have localized therapy, example, surgery and radiotherapy for the localized tumor. And then you can also have systemic therapy, usually for blood cancer and those with distant metastases. Okay. And then localized and systemic therapy for those patients with a local tumor, solid tumor, and then with distant spread already with far advanced disease. So the localized and systemic therapy are usually combined or one after the other. The non-mainstream modalities of treatment of cancers. So you will be encountering these two terms frequently: alternative medicine and complementary medicine. There are other terms like integrative that just focus on these two. Alternative medicine is typically used to describe treatments that are given instead of the standard. Okay, so alternate to the mainstream ones. Okay, complementary medicine usually describes therapies that are being used with the regular medical treatment. Okay, so this can be combined with the usual standard treatment. Okay, but the evidences are not very clear yet. That's why it's part of the alternative medicine. The non-mainstream or alternative medicine treatment of cancer can be defined as loosely as a set of products, practices, and theories that are believed or perceived by their users to have a healing effect of medicine, but whose effectiveness has not been established using scientific methods. So the commonly used non-mainstream medicines are herbs and herbal medicine, special diet, supplements including high dose of vitamins, acupuncture, lifestyle medicine such as healthy eating, physical activity, and other healthy behaviors, but without the use of medicine. So the main difference between the mainstream and the alternative medicine for cancer is the approach. Okay? Whereas the mainstream medicine treats symptoms and problems in a certain given area directly, alternative medicine focuses on the cause and prevention, overall health, and non-conventional and often natural treatment. Any cancer treatment can be used as the primary treatment, but the most common primary cancer treatment for the most common types of solid cancer is surgery. Okay, this is for the solid cancer. Okay, the most common is still surgery. For blood cancer, it will be chemotherapy, okay, or systemic therapy. If the cancer is particularly sensitive to radiation therapy, okay, and chemotherapy, okay, then one can use one of these therapies as the primary treatment instead of surgery. Okay. So the choice of the cancer treatment is basically based on the track records, okay, using evidences of effectiveness on certain types of cancer. In selecting the treatment, I'll just give you the principles. Okay. Selecting treatment processes. Okay. The physician uses the BRCA, okay, data. Okay. B stands for the benefit in terms of goal of treatment, the risk in terms of side effects, inconveniences, okay, complications, costs, peso value or dollar value, it depends. Then whether it's available, readily available, okay. And so the physician usually gives or should give the list of various options of treatment and then gives the data on the BRCA, okay, which is not commonly done by physicians, okay. So with the data given, the patient is asked what or she prefers. The physician can give advice to the patient, but the patient has to be the one to decide, or his or her family. So example of BRCA comparative analysis of treatment procedures, okay, 1, 2, 3, okay, in terms of benefit, this one has the greatest survival rate, okay. Option 3 has the least survival rate, and then option 2 in between, 1 and 3, and then assuming that all are have acceptable risk complications, okay, and then the cost is 5,000, 6,000, 3,000 for 1, 2, 3, and then let's say all are readily available. Okay, so if you were to choose which one that would be best for you, I don't think you will be choosing the least survival rate. You will be choosing the greatest. Okay, so this is when you say BRCA, priority is given to the B. Okay, you cannot look at the cost as number one as the priority factor to consider. Okay, the cost is 3,000. You can say, "Hey, 3,000. It's only 3,000. Then I'll choose that one." No, you have to give priority to the goal of the treatment. Okay, so here in terms of survival, the greatest survival is option 1. So this is the best. And then in terms of cost, okay, 5,000 is reasonable compared to 6,000. Okay, so the best option here will be option 1. Some words of caution on the alternative medicine for cancers. Some of these therapies promise wellness using a method that sounds simple, wholesome, and without harmful side effects. But this is not always true. Delaying surgery, radiation, chemotherapy, and other mainstream treatment by using an alternative therapy can allow the cancer to grow and spread to other parts of the body. And evidences have shown that people who use alternative medicine in place of the standard cancer treatment have much higher death rates. Okay. So in a journal reported, there are a lot of reports coming out now, but this is the one that I took is just 2017 from the National Cancer Institute. So after a median of 5 years follow-up, okay, patient with breast and colorectal cancer were nearly 5 times as likely to die if they have used an alternative therapy, okay, compared to if they use a conventional treatment. Okay. So you have higher death rates with alternative medicine. Some alternative therapies have been reported to cause serious problems or even death or complications. Certain vitamins like vitamin E, high dose minerals can increase the risk of cancer or other illnesses, especially if too much is taken. Let's now go to surveillance. Surveillance after cancer treatment. This is after cancer treatment. Okay, so it's defined as simply monitoring. Monitoring for what? Monitoring for recurrence after all evident cancers have been eradicated after a curative treatment. Remember our definition of curative goal, we remove all evident cancers. So surveillance after that will be monitoring for recurrence. Okay. Then for those with palliative treatment, okay, it's monitoring for progression or regression, okay? Whether all the evident cancers are not or cannot be eradicated totally. So this is during the palliative treatment, okay? So you monitor for the progression, if the cancer is still present, no curative treatment is being done, if there's progression, or if you use an alternate, a drug which is on a trial basis, then it regress. Okay, so that's part of the surveillance. Okay. So the issues on surveillance here will be questions asked by whom, how long, how often, and what methods. I will discuss this one by one. By whom? By the oncologist, okay, with or without a family physician, okay. A family physician can also sometimes be helpful, okay, in terms of psychosocial therapy, psychosocial support, okay. And then the basis for choosing which who will monitor, okay. So whom you prefer as a patient, as the relatives, okay. In terms of using this criteria: competence of the doctors or the oncologist or the physician, expertise, professionalism, holistic and compassionate care, cost, availability, convenience, etc. Okay, so this may be the factors that you will use in choosing who will be the oncologists, who will be the physicians, who will be taking care of the monitoring of the outcome. So we have been hearing a lot about oncologists, okay? But what is essentially an oncologist? An oncologist is basically a physician with specialty in cancer management, okay? Various types, okay? So you can have an oncologist who is a surgical oncologist who specializes in managing, in operating on solid cancers, okay? So surgical oncologists. So surgeons can also be oncologists. Medical oncologists are those usually internal medicine, okay, who specializes giving drugs, okay, particularly chemotherapy, okay, to patients with cancer, okay. And then of course, a subset here will be, you can have a pediatric oncologist, okay. So the pediatrician who specializes in treating cancer patients are called pediatric oncologists. Radiation oncologists are those who specializes in giving radiotherapy as their treatment. Okay, so you have radiation oncologists. Okay, so as I said, there could be others. No, sometimes hematologists can also be called, can be subclassified under medical oncologists because they treat patients with blood cancers. Okay, so oncologist is not limited to one type of doctors. Okay, it can be surgical, medical, pediatric, even gynae onco. Okay, I have to add gynae onco. There's another specialty. Gynae onco is another specialty. Okay, so you just have to choose one or more as indicated, and as preferred, as I said, use this criteria in the choice of people or doctors who will monitor the outcome. The next issue is how long. Okay. So two settings. For those with curative treatment goal, it's a lifetime monitoring, as all cancers have potential to recur even after a long period of remission. Even after 10 years, 15 years, okay, 20 years, it can recur. Okay. For those with palliative treatment goal, so how long to monitor until signs of progression or regression occurs. If this occurs, either one, then another round of decision will have to be made. Okay. Then the other factor to consider in terms of how long until a call or decision for hospice care is made. That means when you say hospice care, no more aggressive anti-cancer treatment. Okay. The last factor is how long until, it can be until the end of life of the patient. How often? Again, another two situations. In terms of monitoring for the immediate results of the treatment, okay, so right after treatment, shortly after treatment, you have to monitor the results, okay, and then monitoring for recurrence of cancer after a curative treatment. So these are the two situations. So in the first situation, in which somebody just underwent treatment, okay, so the monitoring, how often, okay, so basically, when in this situation, you're monitoring the results of the treatment in terms of side effects and complications of the treatment, and then also the response to treatment, such as chemotherapy, radiotherapy, etc. Okay, So the duration of monitoring, how often, is dependent on the type and duration of the treatment. Okay, so because you have different types: surgery, chemotherapy, radiation. Okay, surgery is one sitting. Radiation, you have probably about 1 month and a half. Okay, chemotherapy usually about 4 months to 6 months. Okay, and then it also depends on the recuperation time. Okay, during the treatment, then expected response, such as 2 to 3 months after chemo, etc. So frequency can range from daily monitoring, okay, to every month, especially those undergoing cyclical chemotherapy. So average of 6 months. So monitoring for recurrence after curative treatment of the cancer. It depends on the type of the cancer, treatment done, the usual prognosis, the time of the treatment, whether it's soon after or long after the treatment, then the mindset and personality of the patients, etc. Okay. So the general guidelines will be more often for those with higher risk for recurrence, such as an aggressive type of cancer, which will recur in a few months, in the first year. Okay. So early post-treatment, say 1 to 2 years when recurrence usually appears. Okay. Usually during the first 2 years, most of the recurrence appear there. So the frequency of monitoring will be often during these first 2 years. And then for anxious patients who need frequent psychological support from physicians, it will be more often. Okay, not every day, every month, every 2 months, every 3 months. Okay, that's the usual. Okay. So the next issue or question is what methods. Okay. Basically, there are 2 methods: symptom sign directed surveillance approach and regular screening instrumental laboratory diagnostic test directed surveillance approach. So 2 types. I will explain this. Okay. So in the symptom sign directed surveillance approach, the patient's symptoms and physician sign findings will direct what laboratory tests will have to be done or what instrumentation diagnostic tests will have to be done. So it depends on the symptoms of the patient and also the signs on the physical exam findings of the physician. Whereas in the regular screening instrumental laboratory diagnostic test directed surveillance approach, there is the use of the battery, a whole gamut of screening tests on possible sites of recurrence. So these are done even in the absence of symptoms and signs. Okay. So between the two, okay, if you talk of more cost effectiveness, okay, the first one would be more cost effective. So in the advice of the patient for surveillance, the physician gives or lists the options of surveillance, okay, basically telling the patient there are 2 methods: symptom sign directed and battery of test directed, and then gives the BRCA, the benefit, risk, cost, availability. then with the data given, the patient is asked what or she prefers. Okay, so so basically in surveillance, you have to look at these 3 factors. Okay, in terms of early detection, of course, everybody wants to have an early detection, but you have also to look at the long-term survival, okay, and also the quality of life. Okay, so you have to consider these 3 factors in the benefit: early detection, survival rate, and then the quality of life. Okay, and then of course you list down the risk, the cost, and then the availability of all the diagnostic procedures. So an example here, okay, this is a usual scenario. Okay, for the option 1 is symptom directed. Option 2 is battery of tests. Okay, so in terms of early detection, so you will have more earlier detection. An advantage of option 2, battery of tests, because you're doing a lot of tests now, you have advantage of early detection with option 2 compared to option 1, okay, which is just based on symptoms and sign, okay. Now, for the survival benefits, most of the studies have shown for cancers now that usually their survivals are the same, whether you do the symptom-directed or battery of tests. This is in general, okay, most of the cancers, okay. Now, in terms of quality of life, okay, it's said that the battery of tests will give you a poorer quality of life because you know you have recurrence earlier on, and then you're suffering from mental anguish, depression for a long period of time, right? Compared to somebody who had a later detection of the cancer, but would just died at the same time with the one using the option 2. So it has a better quality of life, okay? So you have to consider all of these three factors in the benefit. Then you choose, okay? And then the other one is that in the battery of tests, you have a lot of false positive, false alarms. And of course, the cost. Okay, the cost of the battery of tests is far greater than the one with the symptom directed. Okay. Prognosis. Prognosis just means to estimate how the cancer will go for you. Okay. So it means the course of the cancer without treatment. And if with treatment, whether it's done curatively or palliatively, what will be the likely outcome? The chances of recovery from the cancer is another way of looking at the word prognosis. Chances of response to treatment, whether there's a cure or remission or recurrence. Okay? And then usually you can use the estimate of 5 to 10 year survival rate and the median survival rate. This is the usual measures that physicians use. The prognosis of the cancer is dependent on the type of cancer, the stage, the inherent biologic behavior of the cancer, which most of the time we don't know. Okay, some are really inherently fast growing, some are slow growing. Those with or without comorbidities and other illnesses, and the gravity of the comorbidities, and then the track records of the cancer in terms of the response to treatment, in terms of their survival rates. Okay. So studies on the 5 to 10 year survival rates and median survival rate can be done by stage of the cancer and also those with or without treatment. So when you talk about 5 to 10 year survival rate, some would also go as high as 15-year survival rate if there are data. Okay. So at the moment, they just use 5 to 10. Okay. So this is the percentage of patients who are alive 5 years for 5-year survival and 10 years for 10-year survival after they were diagnosed or started treatment. So example of data that will be shown to you or given to us will be 5-year survival rate of breast cancers in terms of these 3 staging: localized, regional, advanced. Okay. So the data shows that if the breast cancer is localized, the 5-year survival rate is 99%, very high. Those with regional, with lymph node spread to the axilla, lower, 86. And then those with advanced or distant spread, okay, only 28% will be surviving will be left after 5 years. For the TNM staging, 1, 2, 3, 4, again, you can see that stage 4 has the lowest 5-year survival rate. Okay, highest will be stage 1, 98%. Now, this is a table that shows inclusive of the 15-year overall survival. Okay, so you can see that the longer you follow up this patient for stage 4, initially there are the 10 years there could be 24% still surviving, but in the 15-year, no more patients survive. Okay. Also, you also take a look at the stage 1, 2, 3. As you live longer, the rates, the percentage are also decreasing. Okay. Median survival rate is another measure of the prognosis. So this is the length of time from either the date of the diagnosis and the start of treatment for a cancer that 1/2 of the patient diagnosed with the disease are still alive. Okay. So example of this is usually in terms of months. Okay. So median survival time, two factors that can be two data that can be gathered. Median survival time in terms of with treatment or without treatment. Median survival time based on the stage and based on the types. Okay. So an example here is that in prostate cancer with metastasis, what is the median survival rate for each one of them? Okay. So you can see for the lung cancer, the median survival is 19 months. This means at 19 months, 50% of the patients with prostatic cancer with metastasis to the lungs are still alive. Okay. With liver cancer, 14 months. For bone cancer, longer, 21 months. And then for those with just lymph nodes, 32 months longer. Okay. So the last topic here will be palliative and hospice care for cancer patients. These are the two terms that one will encounter in the medical management of cancer patients, which most Filipino lay people are not familiar with, and which most Filipino physicians do not acquaint their patients with. Okay. So these two terms are palliative care and hospice care. So what's the difference and similarities? Palliative and hospice care are being used in patients with advanced cancer patients who have little or no prospect of cure and who are exposed to die or who are expected to die, and for whom the primary goal is to optimize the quality of their remaining life or time on earth. So both palliative and hospice care have one thing in common. They provide comfort in terms of physical, mental, spiritual comfort for the advanced cancers. Palliative care can begin at diagnosis and at the same time as treatment. It can consist of anti-cancer treatment, even though the treatment may not be very promising. Okay, so you can still use anti-cancer treatment. So example, you have advanced cancer here, then with the goal is just palliative goal, not curative goal, then you proceed with the palliative care. Okay. Then hospice care begins after treatment of the cancer is stopped. One has decided that no more anti-cancer treatment because it's chances are there will be no cure anymore, there will be no response. Okay. So when it is clear that the person is not going to survive the cancer, you can stop the anti-cancer treatment already. So in which case, the care still continues, and we call it hospice care, okay, giving comfort to the patient. Okay. So note the difference between palliative care and hospice care. Palliative care will come before the hospice care. Okay, summary takeaway. I have expounded on the treatment, surveillance, prognosis, and palliative and hospice care for cancer patients. I won't repeat the summary for each anymore. So another takeaway in relation to our patient empowerment program, be always in touch with reliable medical information on fundamentals and generalities in medical management of cancer. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of a cancer that you may get in the future, okay, or for your relatives. So with that, I end my pep talk entitling Fundamentals and Generalities in Medical Management of Cancer in general. This is in general, okay, part 2, okay. So I hope I have empowered you to have a better understanding of the fundamentals, okay, and generalities in the medical management of cancer, okay, part 2. So before we go to the question and answer portion, let's take a reminder, take an online learning and evaluation test exercise for mastery of learning. Okay, get a perfect score, 50 OLETES, 1 voucher for free medical consultation, telemedical. Okay. Let's now have a group picture taking before we start the open forum.